Hello, everyone. Welcome to Pod Bites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Jana Atef, your host for today's episode, and I'm joined by Lema Sibai to discuss schizophrenia and related disorders.
Thanks, Jenna. I'm very excited about today's topic. Schizophrenia is often misunderstood, and we're here to clarify what it really is, how it presents, and what treatments are available. We'll also dive into related disorders like schizoaffective disorder, brief psychotic disorder, delusional disorder, and more.
All right. Before we dive into the specifics, I think it's really important to really understand the core feature that ties these conditions together, and that is psychosis. So, Lema, let's take a closer look into what psychosis really is.
Psychosis is at the heart of schizophrenia and other related disorders. It's not a diagnosis by itself, but a collection of symptoms that reflects a profound loss of contact with reality. When someone is experiencing psychosis, they might have delusions, hallucinations, and disorganized thinking. So basically, their ability to tell what's real and what's not gets severely impaired.
All right. Now let's dive a bit deeper into each of these symptoms, starting with delusions. What exactly are they, and how do they show up in psychosis?
Now, delusions are basically false beliefs that are fixed and unshakable, even when there's clear evidence proving them wrong. Think of them as a disturbance in the content of thought. Delusions can take many different forms. Sometimes, what you may see is known as persecutory delusions, where the individual believes that someone or some group is out to harm or spy on them. For example, thinking the government is tracking them through their phone. Then you have grandiose delusions, where they believe that they have special powers, wealth, or a unique mission, like thinking they're a secret advisor to world leaders. And finally, there are somatic delusions. In this type, those individuals believe that something is physically wrong with their body, like having parasites under their skin without any medical evidence. The key is that these beliefs are unshakable, no matter how much evidence there is against them.
So it's all about the content of thought, right? The person genuinely believes these things, even if they sound impossible to us?
Exactly. That's what makes delusions such a core part of psychotic disorders like schizophrenia.
All right. Let's move on to hallucinations. How do these fit into psychosis?
Now, hallucinations are all about false perceptions, so basically they're tied to the senses. So imagine seeing, hearing, feeling, or even smelling things that aren't actually there. In schizophrenia, the most common type of hallucinations is auditory hallucinations, like hearing voices that comment, command, or criticize. These voices might say things like, "You're being watched," or even give commands to do certain things. Other types include visual hallucinations, where they see things like shadows or figures that don't exist. Tactile hallucinations, where they feel things crawling on or under their skin. And olfactory hallucinations, where they smell something foul or burning without any source. The key difference between hallucinations and delusions is that hallucinations are about perception, while delusions are about belief.
Got it. So, with hallucinations, it's like the brain is creating sensory experiences out of thin air?
Exactly, Jenna. And for the person experiencing them, these perceptions feel 100% real.
Okay, so we've covered delusions and hallucinations. Now, what about disorganized thoughts?
Disorganized thoughts are all about how ideas flow and connect. It's a disturbance in the form of thought rather than the content of thought, which we saw in delusions. So, normally, people's thoughts follow a logical flow, with ideas connecting smoothly and answers staying on topic and making sense. This is organized thoughts. Disorganized thoughts can show up in multiple ways. First, there's derailment, where you will see them jumping from one topic to another without any logical connection. Then there's tangentiality, where they go off topic so much that they don't actually answer the question that you asked. And finally, there's word salad, where they speak in a way that may sound like nonsense or like a bunch of unrelated words strung together. In psychosis, these thought patterns make it incredibly difficult to communicate or follow a conversation.
So, it's like the brain's organizing system for thoughts is broken?
Bingo! And this disorganization is usually why having a conversation with someone experiencing psychosis may feel confusing or fragmented.
All right, let's test our listeners with a practice question. Hearing voices that comment on your actions is an example of which feature of psychosis? The answer is hallucination, specifically auditory hallucination. Okay, Now that we've covered the core feature of psychosis, let's move on to a disorder where psychosis is front and center, and that is schizophrenia.
So, for today's case, we have Ali, a 22-year-old college student who was brought in by his parents. They noticed that he's been isolating himself, neglecting hygiene, and making paranoid statements like, "My professor wants to kill me." He's also been talking to himself, appearing to respond to voices that aren't actually there, and has shown disorganized speech like jumping between unrelated topics.
Okay, Lema, tell us about who gets schizophrenia and why.
Schizophrenia affects about 1% of the population worldwide and typically starts in late adolescence or early adulthood. It usually starts earlier in men, ages about like 18 to 25 years old, and starts later in women, about 25 to 35 years. One of the strongest risk factors for schizophrenia is actually genetic predisposition, and actually, there's a 10% risk if a first degree relative has it, and a 50% risk for identical twins. Substance use during adolescence, especially cannabis, can double the risk for schizophrenia. Another risk for schizophrenia is prenatal stressors like viral infection or malnutrition during pregnancy. And finally, people who live in urban areas are usually at higher risk than rural areas, possibly due to increased stress and social isolation.
Okay, got it. So, genetics, cannabis, and urban areas. And what's the clinical definition of schizophrenia?
Schizophrenia is a chronic psychiatric disorder characterized by episodes of psychosis, including delusions, hallucinations, and disorganized thinking, lasting at least 6 months with at least 1 month of active symptoms. It causes significant impairment in social, occupational, or personal functioning.
At least 6 months. Okay. All right. Can you tell us a little more about why schizophrenia happens?
Obviously, so basically, it's a mix of genetics, neurodevelopment factors, and environment stressors. The major theory in the development of schizophrenia is the dopamine hypothesis, where we have a disturbance in the level of dopamine in specific areas of the brain. First, there's too much dopamine in the mesolimbic pathway, and this leads to what we call positive symptoms. So, those are things like delusions and hallucinations. So, imagine that the excess dopamine is creating symptoms that are not normally there. Then, in the mesocortical pathway, there's too little dopamine, leading to negative symptoms. And what that means is that you're losing something that is normally present in people not affected by the disorder. So, these negative symptoms will be things like flat affect and social withdrawal. Other than dopamine, there's also evidence of glutamate dysfunction. So basically, you have reduced activity in the NMDA receptors, which can contribute to cognitive symptoms.
Okay. So, too much dopamine in the mesolimbic pathway causes positive symptoms, while too little dopamine in the mesocortical pathway causes negative symptoms. All right, Lema. What about the actual brain changes in schizophrenia?
Interestingly, the brain actually undergoes physical structural changes. You can see enlarged lateral and third ventricles, which indicates neurodegeneration. You can also see reduced gray matter in the prefrontal cortex, temporal lobes, and hippocampus. So, this loss of gray matter leads to hypofrontality, where you basically have reduced activity in the prefrontal cortex, and this contributes even more to those negative symptoms like the lack of motivation. These structural changes also lead to abnormal connectivity between the hippocampus and prefrontal cortex, which disrupts memory and decision making because remember that the hippocampus is responsible for memory.
Okay, so reduced gray matter and enlarged ventricles. Got it. Now, can you tell us how to diagnose it?
Yeah, sure. So you might suspect that someone has schizophrenia if you see that they have poor self care, flat affect, and lack of eye contact. But most importantly, when you're diagnosing schizophrenia, there are certain things that must be present in an individual according to the DSM 5 criteria. Remember the features of psychosis we talked about, like delusions, hallucinations, especially auditory, disorganized speech, like word salad, grossly disorganized or catatonic behavior, and negative symptoms, like flat affect. The person must have at least two of these symptoms for 1 month. And one of the symptoms has to be one of the three positive symptoms: delusions, hallucinations, or disorganized speech. General signs of disturbance must also be continuous for at least 6 months. And finally, you need to rule out other causes of psychosis like mood disorders, like psychotic features, or substance induced psychosis.
At least 6 months. Okay. And what's the go to treatment for schizophrenia?
We have some non pharmacological treatments like CBT to manage delusions and hallucinations. There's also social skills training to improve daily functioning, as well as family therapy to reduce relapse rates. However, the gold standard is antipsychotics. These drugs are classified into typical first gen antipsychotics and atypical second gen antipsychotics. Typical antipsychotics target D2 receptors to control positive symptoms, while atypical target both D2 and serotonin receptors, so that would target both positive and negative symptoms. Typical antipsychotics include haloperidol, chlorpromazine, and remember they only target D2, so their side effects would be things related to the D2 receptors. So basically, they might experience extrapyramidal symptoms like tremors and tardive dyskinesia. Atypical antipsychotics, though, are drugs like clozapine and risperidone and olanzapine. As we said, these drugs target both D2 and serotonin, so their side effects will also extend to things related to serotonin, like weight gain and metabolic syndrome. Now, remember that clozapine is actually reserved for resistant cases because it has so many side effects, the most dangerous one being agranulocytosis.
Whoa, so clozapine is like the last resort when everything else has failed.
Ding, ding, ding. Exactly.
Okay, now what kind of outcomes are we expecting for someone with schizophrenia?
About 20 to 30% achieve significant improvement with treatment. However, unfortunately, around half of the patients experiences relapses. So, because treatment is so crucial in the progression and prognosis of the disease, early diagnosis and consistent medication are very important. Unfortunately, there are some possible complications. Even though the antipsychotics are very important for these patients, they may be at risk for cardiovascular disease due to side effects. Also, these individuals may sadly find themselves resorting to substance abuse or suicide.
Wow, that really shows us how important treatment is. All right, now let's try a practice question. Which neurotransmitter pathway is most associated with positive symptoms of schizophrenia? The answer is the mesolimbic pathway. The positive symptoms, like delusions and hallucinations, are linked to hyperactivity of dopamine in the mesolimbic pathway. Okay, Lema. So now, I've always wondered, how do we tell schizophrenia apart from bipolar disorder? They seem kind of similar to me sometimes.
That's such a great question. You should remember that in schizophrenia, psychotic symptoms are always present, regardless of the mood. However, in bipolar disorder, the psychotic symptoms only occur during mood episodes, like during manic or depressive episodes. Also, schizophrenia is more likely to have cognitive decline, while bipolar disorder is more likely to have mood symptoms, which makes sense since bipolar disorder is a mood disorder.
Awesome. I think that clears things up. There's another disorder that feels similar to these two. I think it's called schizoaffective disorder.
Yes, schizoaffective disorder. That's actually our next topic.
Oh, great. How about a case for the next part then?
Let's do it. Meet Sada, a 28-year-old woman who presents with episodes of severe depression mixed with periods where she feels usually elated, talks rapidly, and sleeps very, very little. During both episodes, she also reports hearing voices telling her she's being watched, even when she doesn't feel particularly depressed or euphoric.
Whoa, that sounds like a mix between bipolar disorder and schizophrenia, doesn't it?
That's actually a great way of thinking about it. Schizoaffective disorder is a mix of schizophrenia symptoms plus symptoms of a mood disorder, either bipolar type or depressive type. The key is that in schizoaffective disorder, psychotic symptoms must persist, even when the mood symptoms aren't present.
That's really interesting. So, what's the deal with schizoaffective disorder? How common is it and what causes it?
Schizoaffective disorder is less common than schizophrenia. It's seen more in people who have strong family history of schizophrenia or mood disorders, or people who struggle with substance abuse. It can also be triggered by stressful life events in someone who is predisposed.
Oh, does it have types?
Yes, actually, there are two main types. The first is bipolar type, which can have manic, hypomanic, or mixed episodes. Then there's depressive type, which only has major depressive episodes.
Okay, so we can remember it from the name. Depressive type has depressive episodes, while bipolar type has manic or hypomanic episodes. And what exactly goes wrong in schizoaffective disorder?
It's probably a mixture of genetic and neurochemical factors, and there are actually three theories that may be involved. First, we have the theory of dopamine dysregulation. Basically, there's an excess of dopamine in the mesolimbic pathways causing positive symptoms. Then, there's dopamine deficits in the mesocortical pathways causing negative symptoms. Does that remind you of anything?
Oh, that's what we saw in schizophrenia, right?
Yes, this dopamine theory is just like what we saw in schizophrenia. But we have another theory that is also similar between both disorders, and that is the theory of glutamate dysfunction. In this theory, there's basically a reduced activity of the NMDA receptor. This may contribute to both psychotic and mood symptoms. And finally, we also see an imbalance in serotonin, which is why there's an overlap with symptoms of mood disorders.
Okay. So, what makes it different from schizophrenia is the imbalance in serotonin. And how do we diagnose schizoaffective disorder?
When you see the patients, you might see poor self care, flat affect, or disorganized behavior, similar to what you see in schizophrenia, actually. According to the DSM 5, the diagnosis of schizoaffective disorder requires the individual to be affected by psychotic symptoms like delusions, hallucinations, and disorganized speech for at least 2 weeks without mood symptoms. They also must have mood symptoms, either depressive or manic, for the majority of the duration of the illness. And of course, we need to rule out other possible causes of these symptoms like substance abuse or medical conditions.
Okay. So, they would have mood symptoms most of the time and then also have at least 2 weeks of pure psychotic features, right?
Yep, pretty much.
Okay, Lema. Now, tell us how to manage schizoaffective disorder.
No problem, Jenna. Since it's a mix of schizophrenia and mood disorders, it makes sense that we treat it with a combination of drugs used to treat each condition on its own. So, basically, schizoaffective disorder is treated with a combination of antipsychotics and mood stabilizers. The antipsychotics used are usually atypical type like risperidone, olanzapine, or clozapine. What's interesting is that these atypical antipsychotics are effective for both psychotic and mood symptoms, so it's like an added benefit. For the bipolar type specifically, we can use mood stabilizers such as lithium or valproate. Then, specifically for the depressive type, we can use antidepressants, but always combined with antipsychotics to prevent triggering mania. Other than pharmacotherapy, we can also resort to psychotherapy like CBT and social skills training.
Hmm. And what's the prognosis like for these individuals?
The prognosis for schizoaffective disorder is better than schizophrenia but worse than mood disorders. Early diagnosis and consistent treatment can significantly improve outcomes. There are some possible complications, unfortunately. These individuals have cognitive impairment that is pretty significant, even though it's less severe than schizophrenia. They are also at risk for social isolation because of both psychotic and mood symptoms. The most serious problem, though, is the suicide risk in schizoaffective disorder. It's higher in mood disorders alone, especially during depressive episodes.
Whoa, that's pretty scary. So, treatment is very important then.
Yeah, it really, really is.
Okay, now, let's test our listeners with a practice question. In a patient with schizoaffective disorder, which neurotransmitter imbalances is most likely involved in the manifestation of mood symptoms? The correct answer is serotonin. The mood symptoms specifically are most closely linked to serotonin imbalance, which is why SSRIs are often part of the treatment plan. Okay, Lema. So we talked about differentiating schizophrenia from bipolar disorder, but I'm still kind of confused about something. How do we differentiate schizoaffective disorder from schizophrenia?
I'm so glad you asked. This is actually a confusing point for many people, but hopefully it'll make a lot more sense now. In schizophrenia, the psychotic symptoms are constant, and usually there are no mood symptoms. However, in schizoaffective disorder, the psychotic symptoms occur with mood symptoms for the majority of the illness. When it comes to prognosis, schizoaffective disorder generally has a better outcome because it responds better to treatment.
Ooh, that makes so much sense now. Also, I heard that some people get these brief psychotic episodes.
Yes, actually, that's our next topic, so I'm glad you brought this up. For our next case, we have Sara, a 28-year-old nurse who, after experiencing some stress following a family crisis, suddenly started saying her coworkers were conspiring against her. She was seen talking to herself, seemed confused, and exhibited disorganized speech. However, these symptoms completely resolved within 2 weeks without any recurrence.
Oh, it went away completely.
Yep, and this is brief psychotic disorder, and luckily it resolves.
Oh, okay. So who gets it and why?
It's actually quite rare, but it tends to affect young adults, specifically women slightly more than men. It's more commonly triggered by extreme acute stress or trauma, like a sudden loss or a major life change. In this disorder, individuals experience sudden psychotic symptoms, but they later fully return to their previous normal level of functioning. Like many psychiatric disorders, brief psychotic disorder relies on genetic predisposition, and it's interesting that people would be at risk for this disorder if they have a first degree relative with schizophrenia.
Oh, I've also heard about women experiencing psychosis after giving birth. Is that related?
Yeah, actually, women in their postpartum period are also at higher risk for this disorder. This is known as postpartum psychosis.
Oh, okay. Now, can you tell us a bit more about how it's defined clinically?
Brief psychotic disorder is defined as a short term sudden onset of psychosis, characterized by at least one of these symptoms. And if you remember, those are delusions, hallucinations, disorganized speech, and grossly disorganized or catatonic behavior. So, at least one of these symptoms must be there and it must last for at least 1 day, but less than 1 month. And you should exclude any mood disorders, substance use, or other medical conditions.
Okay, so a psychotic symptom for less than 1 month, right?
Yeah, exactly.
What exactly goes on in the brain to make the person go into psychosis all of a sudden?
The exact pathophysiology isn't fully understood, but they think it involves a sudden dysregulation of dopamine, like everything else we talked about, in the mesolimbic pathway. So, if you remember, that's similar to schizophrenia, but the difference is that this happens for a much shorter duration, hence why it's brief. And this dopamine dysregulation is probably triggered by high levels of stress and causes the acute symptoms you see, like hallucinations and delusions.
That sounds really scary. So, how do we manage it?
The good news is that brief psychotic disorder usually resolves on its own. So, when you're treating it, you're mostly focusing on supportive care. You can manage the acute symptoms by using antipsychotics like olanzapine or risperidone for a short duration. You can also use benzodiazepines as sedatives for agitation or insomnia. And finally, you can also try psychotherapy, as it helps those patients process the triggering events and develop coping strategies. And as we said, it generally has an excellent prognosis, and these patients usually have a full recovery within a month if they're treated right.
All right, thanks, Lema. Now, let's try a practice question. Which neurotransmitter is most likely to be involved in the pathophysiology of brief psychotic disorder? The correct answer is dopamine. So basically, remember the dysregulation of dopamine in the mesolimbic pathway, which leads to the acute symptoms of brief psychotic disorder. Now, something important to discuss is how would we differentiate brief psychotic disorder from schizophrenia?
Yeah, so there are three main differences: duration, prognosis, and negative symptoms. So, first of all, as we said, brief psychotic disorder lasts less than 1 month, while schizophrenia would last at least 6 months. Then, we also said that you would expect a full recovery in brief psychotic disorder, while in schizophrenia, it often requires lifelong management. And finally, an important difference is that you can commonly see negative symptoms in schizophrenia, but not in brief psychotic disorder.
Okay, so brief psychotic disorder is usually below 1 month and has a great prognosis and no negative symptoms. That makes sense. Now, take us to the next case.
All right, for our next case, we have Mr. H, a 55-year-old accountant who has become convinced that his wife is trying to poison him. He has no history of psychiatric illness, and aside from this fixed belief, he appears well functioning. His behavior hasn't changed significantly, and he's still working and managing his responsibilities without issue.
What does this patient have?
He has delusional disorder. This disorder is characterized by the presence of one or more non bizarre delusions for at least 1 month, without any other symptoms seen in schizophrenia, and without significant impairment in daily functioning. So, unlike schizophrenia, there's usually no cognitive impairments or major personality changes like odd or erratic behavior.
Okay, you mentioned non bizarre delusions. We already went over delusions briefly, but how about we go into more details of what non bizarre means and what different types are?
Sure. So, delusions and delusional disorder are non bizarre, and that means that these beliefs could technically happen in real life. Let's break them down together. First, we have persecutory delusions.
Oh, this is where they believe when someone is out there to harm them or spy on them.
Yes, then there's jealous delusions.
Yeah, in this one, they may believe that their partner is unfaithful without any real evidence.
Yes, you're on fire. Oh my God. Okay, there's also somatic delusions.
Oh, like believing something is wrong with their body, even though medical evidence shows otherwise.
Yep. And we also have erotomatic delusions.
So, like thinking a famous person is secretly in love with them?
Exactly. And finally, there's grandiose delusions.
Ooh, that's where people believe they have exceptional abilities or importance.
Exactly. So for our case, Mr. H has the belief that his wife is trying to poison him. Now, pop quiz, my turn. Which type of delusion do you think that is?
Persecutory delusions?
Yes, good job. This is classic persecutory delusion, where they really believe that someone is out to hurt them.
Okay, that clears up the types of non bizarre delusions. But why would someone develop this disorder?
It's usually seen in individuals in their 50s, and while the exact cause isn't clear, genetics and neurochemical imbalances, oh my god, what a surprise, specifically involve dopamine dysregulation, probably play a role. It could be triggered by stressful life events and social isolation.
Okay, and how do we diagnose it?
The key is to identify those non bizarre delusions. Then, to diagnose delusional disorder, these delusions have to last at least for 1 month without other schizophrenia symptoms. So basically, there are no hallucinations, or there may only be brief ones related to the delusion. Also, the individual's personality is usually intact because, other than the delusions, they appear normal. Another key is that there is no significant functional impairment, so basically, they can still work and manage their daily tasks. And finally, before you diagnose it, you need to rule out any possible causes of delusions, like substance use or medical conditions.
So, the main thing for delusional disorders is having delusions for at least 1 month without other psychotic symptoms. But wait, how do we treat it? Do we also use antipsychotics?
Jenna, you're on the money. Yes, that's exactly what we give. Antipsychotics are actually the first line treatment for delusional disorder. Now, other than psychotics, cognitive behavioral therapy, or CBT, can help to change their delusional beliefs. We can also give SSRIs if the delusions cause them significant anxiety or depression. Unfortunately, though, treatment can be challenging because patients often don't see their beliefs as false. They truly and completely believe them. And for that reason, they often refuse treatment. So it's really important for the doctor to build trust with the patient.
So, treatment wise, we can use antipsychotics, CBT, and SSRIs. And what's the outcome like for someone with delusional disorder?
Prognosis is generally better than schizophrenia, obviously, especially if they accept treatment early on. However, untreated delusions can lead to social isolation, conflict, and even violence in some cases. It may even lead to suicide, especially in individuals with persecutory delusions.
Now that we've covered the psychotic disorders, we also need to consider some possible differential diagnoses when we're assessing a patient with psychotic features. It's important to know what else can look like schizophrenia but isn't quite the same. So, before we jump into the recap, let's quickly run through some of these differentials.
Absolutely, and I'm gonna need a little bit of help. I'll start. Starting with mood disorders. Sometimes individuals with depression or bipolar disorder can experience delusions only during mood episodes. The key point here is that psychotic symptoms and mood disorders only appear during mood episodes, unlike schizophrenia, where they can occur at any time.
Then there's Parkinson's disease. So basically, many patients with advanced Parkinson's can actually experience hallucinations and delusions due to dysregulation of dopamine, especially if they're taking high doses of dopaminergic medications for their Parkinson's.
Then we also have postpartum psychosis. We already mentioned this one pretty briefly, but let's go a bit deeper. It's triggered by hormonal shifts after childbirth, and it can cause delusions, hallucinations, and mood swings. It's linked to bipolar disorder and usually starts within 2 weeks postpartum. Treatment here involves antipsychotics and sometimes mood stabilizers.
There's also schizophreniform disorder, which is pretty similar to schizophrenia but with a shorter duration. So, remember how we said that symptoms in schizophrenia last for more than 6 months? Well, here in schizophreniform disorder, symptoms last less than 6 months. If symptoms persist beyond that, the diagnosis often changes to schizophrenia. So, you can think of it as a shorter form of schizophrenia, in a way.
And finally, we should think of substance or medication induced psychotic disorder. Remember what we mentioned like 100 times? From the name, you know that this can be caused by drug or alcohol intoxication or withdrawal. It's especially seen with amphetamines, cocaine, PCP, or alcohol withdrawal. Symptoms are usually brief and tend to resolve once the substance is cleared. However, sometimes the symptoms can persist for weeks if they are triggered by certain substances like cocaine or PCP. The key takeaway is to always consider these alternatives, especially if the timeline, substance use, or mood symptoms don't quite fit with schizophrenia.
So, in our differentials, we should consider mood disorders, Parkinson's disease, postpartum psychosis, schizophreniform disorder, and substance-induced psychotic disorder. And we need to understand the differences between them in order to make the correct diagnosis. Okay, Lema, so we've covered quite a lot today. How about a quick recap of the key points?
Okay, stay with me. So, starting off with the core of psychosis, we talked about the three big symptoms: delusions, hallucinations, and disorganized thoughts. Delusions are fixed beliefs that can be bizarre or they can be non bizarre, like thinking your professor is out to get you. Hallucinations are more commonly auditory in schizophrenia, which people hear voices that aren't actually there. And finally, disorganized thoughts lead to things like derailment or word salad, where someone's speech jumps between topics with no clear connection.
And for schizophrenia, we should keep in mind that it affects about 1% of the population and usually starts in the late teens to early 30s. Symptoms have to last at least 6 months and include both positive symptoms, like delusions and hallucinations, and negative symptoms, like flat effect and social withdrawal. Also, don't forget the dopamine hypothesis, where too much dopamine in the mesolimbic pathway leads to positive symptoms, while too little dopamine in the mesocortical pathway leads to negative symptoms. And finally, treatment is all about antipsychotics, both typical and atypical antipsychotics, plus CBT to help manage persistent delusions.
Then we went over related disorders, which had some key differences. First, schizoaffective disorder is a mix between schizophrenia symptoms and mood disorder symptoms. In this disorder, they experience mood symptoms most of the time and then also have at least 2 weeks of pure psychotic features. Treatment involves a combination of antipsychotics and mood stabilizers. Then we discussed brief psychotic disorder. This one's got sudden onset and short duration. Basically, the symptoms last less than 1 month and usually resolve completely. The episode is often triggered by acute stress. And finally, there's delusional disorder, which is characterized by non-bizarre delusions lasting at least 1 month without the other symptoms of schizophrenia. People can function pretty normally otherwise, and treatment includes atypical antipsychotics and CBT.
We also touch on some differential diagnoses to keep in mind. So, with mood disorders, remember that psychotic symptoms might only show up during the episodes of mood symptoms, not all the time. With Parkinson's disease, look out for hallucinations and delusions due to the dopamine dysregulation, especially in patients on high doses of dopaminergic medication to treat their Parkinson's. Then, for substance-induced psychotic disorder, it's often triggered by drugs like cocaine, amphetamines, or PCP, and usually resolves once the substance is cleared from the system. In schizophreniform disorder, it's pretty much schizophrenia but shorter, so symptoms last less than 6 months. Finally, postpartum psychosis typically starts within 2 weeks of childbirth and is often linked with bipolar disorder. Treatment focuses on antipsychotics and mood stabilizers.
And don't forget the bigger picture. Early diagnosis and a mix of antipsychotics, mood stabilizers, and psychotherapy are key to managing all these disorders effectively. Understanding the differences between them and understanding neurotransmitter pathways can really help with making the correct diagnosis and treatment plan.
Wow, that was a solid recap. Hopefully we were able to hit all the high yield points. And that wraps it up for today's episode of Pod Bites.
Yeah, and thank you everyone for tuning in. We hope this episode helped make things a little bit clearer.
If you enjoyed this episode, make sure to follow us so you don't miss out on the next one. Also, don't forget to leave us a review in the discussion below so we can keep improving with each episode. Take care, stay curious, and we'll catch you in the next episode.